Hello, my name is Dr. Chester Griffiths. Today I'm going to discuss with you the Eustachian tube, a source or the source of middle ear disease. Historically, we've treated the effect of Eustachian tube dysfunction. Now we have a technology that can treat the cause. Both myself and my colleague, Dr. Courtney Volker, who is the head of neurotology lateral skull-base surgery and ear disease treatment and surgical approaches, including cochlear implantation of the Pacific Neuroscience Institute, are excited to offer this new advance to our patients, which we previously did not have to offer. We'll review the anatomy of the Eustachian tube, physiology of the Eustachian tube, and the current treatment of these disorders. But first, I'd like to introduce you to our novel institute, the Pacific Neuroscience Institute, bringing all the neurosciences from clavicle to follicle under one roof. Myself and Dr. Volker are involved with the eye, ear, and skull base centers of excellence of the institute, along with the other 8 centers of excellence that comprise the neurosciences. We currently have 38 neurosciences scientists, surgeons, and physicians, and ancillary providers that offer neuroscience diagnosis and treatment. The premise of the Institute is prividemics, meaning a commitment to personalized patient-centric care, which is our focus, with academic research and curiosity and discovery, which is our passion, to be able to bring the latest and greatest diagnostic and treatment options to our patients, and to be involved in research and discovery of the next best in the future. Let's now discuss the anatomy of the Eustachian tube. It is divided in 2 parts. 1/3 of the Eustachian tube in the superior and lateral aspect is housed in the temporal bone. Additionally, the cochlea, the snail-shaped organ of hearing, the balance canals, the middle ear and eardrum, and external canal are housed in this bony structure. This is an adynamic area of the Eustachian tube, comprising 1/3 of its length. The dynamic portion of the Eustachian tube, meaning that it moves and it opens and closes, is the cartilaginous portion of the Eustachian tube, comprising 2/3 in the inferior medial aspect, draining into the back of the nose in the nasopharynx. It is lined by cilia, which we'll review next. The purpose of the Eustachian tube is to equalize the pressure in the middle ear space, allowing efficient transmission of sound. This is a photomicrograph of the Eustachian tube. This is a half-moon cartilage, so it's not a complete circle, allowing this lumen to open and close. And it is attached to this muscle that is attached to the palate, called the tensor veli palatini muscle. This is a more superior lateral aspect of the Eustachian tube. And as you note, the cartilaginous portion is at the superior aspect, and it is attached to the tensor veli palatini muscle. The importance of this is that thousands of times a day, with respiration, phonation, and swallowing, this muscle fires, thus passively equalizing the pressure and atmospheric condition in the middle ear space passively. If you've ever had a cold and you have noted a little bit of a Rice Krispies crackling sound in your middle ear, and that's related to edema, and then you're feeling that passive equalization of the Eustachian tube. It is extremely vital physiologic and anatomic function of the Eustachian tube cartilaginous portion, and the origin of the Eustachian tube dysfunction. The cilia are hair-like structures that propel the mucus down into the nasopharynx. It's comprised of 95% water and mucin, along with secretory IgA, which is an antibody that also controls viruses and bacteria. This is an example of the ciliated cell and the secretory cell secreting this mucus, and it flows down into the nasopharynx, preventing the bacterial migration into the middle ear space, which causes a otitis media or middle ear infection. Today we're going to review the main issue of dilatory eustachian tube dysfunction. There are 3 other categories of eustachian tube dysfunction, including patchless eustachian tube, meaning it's too open, usually related to severe weight loss, and acute barometric challenge or trauma eustachian tube dysfunction associated with rapid descents in altitude, mainly on airplane flights. Although this can be an acute cause of eustachian tube dysfunction, many times there is long-standing scarring, and then when there's a change of altitude, patients really have what we call that barometric challenge. What are the symptoms and effects of eustachian tube dysfunction? Ear disease, hypoaeration of the middle ear space, fullness in the ear, a conductive hearing loss, mild disequilibrium. Ear infections, otitis media of all types, tympanic membrane disorders, including retraction of the eardrum, lack of vibration, and perforation, and finally a benign cystic epithelial tumor called a cholesteatoma. All of these processes are related to the dysfunction of the eustachian tube. Historically, we've treated the effect of eustachian tube dysfunction as we had no other solution. Since the 1800s, there has been 7 different ventilation tubes proposed. Then, in 1952, Dr. Armstrong repopularized tubes, and thus the Armstrong ventilation tube is depicted here. There's long-term tubes, which are called T-tubes, and collar button, which last anywhere from 6 months to a year and a half. They are a surrogate eustachian tube, providing continuous ventilation of the middle ear space and permitting air fluid to escape. This is just treating the effect, not the cause of the dysfunction. This is an example of an animation of the eustachian tube dilation procedure, the new procedure to treat this eustachian tube issue. This is demonstrating the cartilaginous portion of the eustachian tube with the balloon slid into it and dilating the eustachian tube cartilaginous portion. We perform this over 5 minutes per side, sequentially dilating, breaking the scar tissue. This is a surgical video demonstrating the actual procedure. This is the eustachian tube orifice. This is the cartilaginous torus tubarius, which is attached to the tensor veli palatini. This is the balloon dilator being advanced into the eustachian tube, and then it will be inflated, thus expanding and breaking the scar contracture of the eustachian tube, allowing it to then open and close. This is demonstrating the dilation of that balloon. This is done sequentially over 5 minutes, and you'll note in the next portion of the video, here is the balloon. We will deflate it, remove it, and you'll notice the significant increase in size of that eustachian tube opening into the back of the nose. As noted right here. These are photographs of the same procedure. This is before a eustachian tube dilation. You note that there is very narrowed constriction of the opening, placement of the balloon into the eustachian tube, constricted opening, dilating the opening in the eustachian tube, and thereafter the result of the eustachian tube dilation. Pre and post, you can see a pretty dramatic improvement in the size of the orifice or the opening of the eustachian tube, but most importantly, that then allows that tensor veli palatini muscle to actively aerate and pump action into the middle ear space. So why does this work? What is the cause? The cause of eustachian tube dysfunction is a result of recurrent inflammatory conditions, otitis media or tubitis, otherwise known as chronic ear infections. Whenever there is an infection and inflammation, the natural course of healing results in scarring and fibrosis, thus locking down that Eustachian tube, not allowing it to expand or contract. Thus, the cartilaginous canal over many, many years does become scarred and stiff, and it cannot passively equalize the pressure, thus leading to the middle ear disease that we highlighted earlier. Why does this work? Because the treatment is scar contracture release. We're releasing that scar band that is almost like concrete, preventing the expansion of the Eustachian tube. Releasing the scar contracture allows normal muscular function, equalization of the pressure. And the beauty of this procedure is that really no active rehabilitation is necessary, because just by breathing through your nose and mouth, swallowing, speaking, that palatal function is automatically serving as a pump action passively. Now, of course, we have patients do it actively right after the procedure, but the nice aspect is that the rehabilitation is done as a passive physiologic function. So what are the results? So initially, for FDA approval in 2016, there was a reported 61% success. But the real question is, does it last? This is a published article back in 2019 amongst 12 centers, and it did show that after 12 months, there was a 64% improvement in patients. In my opinion, one of the most amazing aspects of this procedure is that normal eardrum movement was achieved at 12 months. So not only is the Eustachian tube functioning normally, but that locked in, sucked in, retracted eardrum in 2/3 of the patients is vibrating and moving normally after this procedure. Any procedure that has a 2/3 automatic success rate is one that is a gold standard. And of course, there is probably 15% of people that have partial responses. Thus, this is really a valuable technology to treat this disorder. So what are the risks of Eustachian tube dilation? It doesn't work. In anywhere from 1/3 to 15% of patients, it may not work. Just initially. Sometimes the scar tissue, you may need to perform the procedure twice to break up that scar tissue. But in the majority of patients, as noted in the research studies, it does work. One of the risks is patchless Eustachian tubes, that is open too much, but that usually resolves over time. But the beauty is that there's to date no major reported complications. Thus, the risk-benefit coefficient is great. It's effective plus low risk equals a great risk-benefit coefficient. So let's hear from patients.
Yeah, so before the procedure, flying.
And it was a Eustachian tube dilation.
Yeah, Eustachian tube dilation procedure. Before that, every time I flew, I would feel nauseated, I would throw up, I would be beyond dizzy, that all I could do was immediately, when I landed, go somewhere and go to sleep. That was the only option I had. I could not hang out with friends or do anything. And even driving my kid to school or any time longer than like 15 minutes in the car, I would just feel off and dizzy, and it was just horrible, any sort of like fast movements. Now, after the procedure, I flew and had zero issues. I had, maybe a slight little headache or something, but that was it. My ears were totally fine. I got off the plane, I went and hung out with friends, went and got something to eat, had no issues whatsoever. So, and even driving now, it seems like that's been improved. So overall, it's been a wonderful, wonderful experience, and I highly recommend it if you have the same issues that I did. Yeah, or something, but that.
I've had Eustachian tube problems probably since I was 1 or 2 years old, many earaches over the years, mostly on my left side. And several months ago, I forget how many months it's been now, I had the Eustachian tube dilation and all the problems went away. My ears clear without a problem. I haven't had an earache. It's just been marvelous. I can't say enough about it.
And before you had tubes?
Before, my ears stuck closed for I think almost 6 months, and I tried the ear dilation surgery, and almost immediately I popped it, and you could the whole room hear it squeak. And now, few weeks later, it's good as new.
The procedure itself is performed as an outpatient, either at St. John's Health Center or in our surgery center at West Wilshire Medical Surgical Center, which has been in existence for over 25 years, offering superlative care. There's normal activity the next day. Healing is over 6 weeks when we give a Medrol dose pack to decrease the swelling. Manual equalization of pressure is now we're popping the ears every hour while awake for 10 days. Advil and Tylenol is prescribed, as it is not really a painful procedure. Hopefully, I've reviewed the issues with the Eustachian tube dysfunction and have highlighted this really remarkable new technology to address this disease. Here's our team with Dr. Volker and Dr. Lewis and our neurotologist and neuroaudiologist. Here we are in the operating room, having just participated in a cochlear implant procedure. I'd like to give a shout out for one of my mentors, Dr. Howard House, whose career and life was dedicated for the world to hear. Hopefully this has enlightened you, and if you have any questions related to the procedure, please do not hesitate to contact us. Thank you.